All right, we are back. This is Senate Health and Welfare on March 23rd, and now we're turning to H-153, looking at Medicaid reimbursement for home and community-based services. Thank you all for being here and able to testify. We're just going to move right through the list because it's a long group, a big group, and we look forward to hearing what you have to say. We don't want to miss anyone's testimony. So we're going to begin. Molly, thanks for being here. And why don't you introduce yourself for the record and go right ahead.
Wonderful. Thank you so much, Chair Lyons. For the record, my name is Molly Dugan, and I am the Director of Policy and Strategic Initiatives at Cathedral Square. I was previously the statewide SASH Director for about 10 years. Cathedral Square was founded in 1977. We're a mission-based nonprofit, and we provide a really broad array of housing, services, and programs and initiatives to support people, regardless of their age, their background, their ability to pay, to live and thrive in their communities. We're probably best known, however, for our developing, owning, and managing high quality, affordable, independent housing for older adults, as well as those with disabilities. We have over 1,000 apartments housing just over 1,200 Vermonters, primarily in the northwest part of our state. Also, we're known for pioneering the statewide SASH model, which just recently this past summer celebrated 10 years in operation and has served over 10,000 Vermonters. It's also been replicated in other states now. However, our reach at Cathedral Square is broader than even that, and we provide opportunities, resources, and support along the entire continuum of living options. As of last fall, we received a HUD grant, about almost $1 million, and we now operate a home modifications program for income-eligible older Vermont homeowners. This is in 7 towns in Chittenden County. And it's to help them stay living independently in their single family homes. Madam Chair, you'll be happy to know that Williston is one of those towns in Chittenden County, and we've been doing a lot of really great accessibility work in Williston Woods. We have about 1,000 plus people on our wait list for our independent senior housing apartments. So doing this kind of program where we're getting into people's single family homes and helping them with some basic modifications they need to stay in their homes makes a lot of sense. On the other end of the continuum, we operate 2 licensed assisted living facilities, communities, one in Williston that is for people living with dementia and Alzheimer's disease and other dementias, and one in downtown Burlington. Where 95% of our residents at these 2 assisted living communities that we house and care for are at nursing home level of care, 95%. It's this part of our business that brings me in to testify on H-153 today. We fully support H-153 for a number of reasons. First, it provides a path for the Agency of Human Services to determine Medicaid rates that are reasonable and based on the true costs of providing care. We have done recently an estimate, our best estimate, to come up with the true costs of providing care at our 2 communities within what is truly a really complex regulatory payment model. And we've compared the true costs to what we have received from Medicaid reimbursement. The analysis shows that over the past 4 years, what we have received from Medicaid reimbursement covers on average of just 50% of the cost of care for our assisted living residents at these 2 communities. Second, we support H-153 because it provides predictability in budgeting for our assisted living communities that rely so heavily on Medicaid as a payer. Approximately 90% of our 43 residents living in our 2 assisted living communities are Medicaid recipients due to their low income. This is the population we want to serve and that we have been serving since our founding in 1977. But us serving 90% on Medicaid has real financial ramifications. Our costs go up every year due to increases in pay, health insurance, food, supplies, and every year we advocate for some kind of increase. Some years we have seen an increase. For instance, last year we got $1.50 a day on the ACCS side, and then a 3% increase for an ERC, Enhanced Residential Care payments. But other years there have been no increases. This leaves us with razor thin margins and excruciating decisions about how or even if we can keep our doors open. And I thought it would be helpful just to, provide a little more detail about some of these difficult decisions. In 2021, for instance, and clearly this was, deep in pandemic time, but our staffing costs at our downtown assisted living community were over budget by $163,000. This was due to us having to pay for traveler nurses, hero pay for our existing staff, a lot of overtime. And even with a $50,000 donation we got that year and $37,000 of coronavirus relief funding, we ended the year at our downtown assisted living community with a deficit of $186,000. So those decisions are real. The variables that we have to consider are very difficult. Lastly, H-153 is important to us because getting to reasonable Medicaid rates and establishing a predictable rate schedule going forward that reflects annual cost adjustments will go a long way in helping us shore up our staffing levels. We struggled to have a full roster of qualified staff prior to the pandemic and have experienced unprecedented shortages like so many other businesses over the past 2 years. In fact, even with a 3 to 5 year wait list at our assisted living communities, in our downtown community, we were forced to reduce our capacity by 20% over the past few years because of a lack of adequate staffing. Without the changes that are proposed in H-153 for home and community-based providers, we will be forced to continue to reduce capacity at a time when older Vermonters and those with disabilities need our housing and services more than ever. Thank you again for having me this morning and considering my testimony, and I'm happy to take any questions.
Thank you very much. I think it's very complete. Can you restate the deficit for 2021 that you mentioned?
Yeah, so in 2021, we ended the year at and this is just at our downtown assisted living community, the high-rise downtown on Battersea Street. Yeah, so used to be the first 3 floors of that were for assisted living. The rest of the floors were independent. We've now had to reduce capacity for assisted living. So it's just the first 2 floors that are assisted living. But we ended the year with a $186,000 deficit at end of 2021.
Okay, thank you. Senator Cummings says no.
What is the daily reimbursement for assisted living? I remember one of my local nursing homes, it was several years ago, gave us a figure. I thought it was something like $54, $85 a day.
So thanks, Senator Cummings. Great question. I mentioned how it's a complex payment system. And so it's hard to give a $1 amount answer here. I can tell you that we get funding so we're a licensed assisted living facility. We accept, and as such, we accept nursing home level of care patients. We get a base rate from Medicaid that's called the ACCS rate. That currently is $43.75 per day. But on top of that, depending on the level of care, so within the nursing home level of care, there's 3 different tiers, and you get paid a different amount with each tier. So that's the enhanced residential care payment that goes on top of the base ACCS rate. So what's difficult about giving an amount per day is that depending on the person we're serving and their care level, the payment's going to change, and their levels of care change throughout the year. So we may have, you know, a roster of patients at an assisted living facility that is start off getting this payment, you know, in the beginning of the year, and then things change, and you know, we get more or we get less depending on that. So there's a lot of unpredictability because of that. So I'm sorry I can't give you a clearer message. I could follow up with telling you what our average is across our 43 residents, if that would be helpful, Senator Cummings.
You know, this was very small local assisted living, and they only had a few. But yeah, the number came in, you couldn't rent a motel room for what we were paying for assisted living, which included 3 meals a day and medication management and some activity of daily living care. And yeah, I mean, that was the message. And they had sworn they would never hire travelers. And this was before the pandemic. That became their only choice.
Yeah.
So it's not good.
No, and I'm sure we're going to hear more. So, and I think we probably should just keep moving along. So thank you very much. And I know that if we have questions, we will reach out again. So thank you very much.
Wonderful. Thanks so much.
All right. And so Jill Mazza Olsen is here for the record. Good morning.
Good morning. Nice to see all of you. Nice to see all of you back in that space. I'm noticing all the spots where I usually like to stand when I'm in the room. Maybe someday again I'll lean against that filing cabinet in there.
We have a chair reserved for you right over here.
Yeah, I don't like the bench in there. I like to stand against that filing cabinet. So you've actually heard from me this session about our concerns about the Choices for Care program, and I am here focused on that program as always. So as a reminder, I'm the executive director of the VNAs of Vermont, so I represent home health and hospice agencies. Home health and hospice provides a variety of services. So we provide medical services in the home. We're not talking about that in this moment here. We provide maternal child health. We provide hospice. The focus of my comments today is the Choices for Care program. So Choices for Care is our long-term care Medicaid program in Vermont. I think one of the challenges we have really nationally is that we pay for long-term care through the Medicaid programs in each state. It is not a national federal program like Medicare. And I think that's sort of the fundamental flaw in how we've gotten to where we are. So home health agencies provide personal care in the home for individuals who would otherwise qualify for nursing home level of care. So Choices for Care, you have to be nursing home level of care and also meet the income eligibility. It's both. There's a clinical and a financial requirement. And so really anybody who's receiving Choices for Care at home is somebody who would probably otherwise be in a long-term care facility to get care. It's one of the most successful reforms that I think, honestly, any state has ever undertaken. The goal was to get to a place where half of long-term care was provided in the home and in the community. That was the goal, and that's about where we are in Vermont. And many states are at more like 80 or 90% of care in facilities versus the home. The result, though, of that policy is that the acuity levels are really high in the facilities, because anyone who is possible, lots of people who can be cared for, can receive care at home, are getting care at home. So that's all good for those individuals. The challenge, as you know, and you've heard me talk about before, is that the program has never kept up with cost. And so essentially the state has absorbed the savings that are the result of more folks getting care at home and in the community and just repurposed them in other places. There was never a concerted effort to make sure that the rates for those home and community-based providers were keeping pace with inflation, with cost. And so really our rates are simply a reflection of the original rates for the program, and then whatever increases we've managed to sort of scrabble and scrape by over the last 15 or so years. That's what they are. So they're not based on really anything that has to do with cost at this point. And of course, while we have gotten some increases over the last 5 years or so, they've been mostly, they were 2%. Last year we got 3%, all below wage inflation. And even the 7% that the House is sending over to you soon, that's about what wage inflation is right now. So we're not even treading water. Each of my members has shared with each of you, or my members from your communities, what their losses look like in this program and how much they're subsidizing it. And it's substantial, as I know you saw. So what are we hoping for? So first of all, we have engaged in a rate schedule process with DVA on the home health skilled side. And that is, that's working. And so I just want to say that there is that method that I know you're going to hear Alicia Cooper talk about has been working. We've identified a payment model for skilled home health and have started to see those rates start to move up a little bit as it gets implemented. That's a little simpler because there's a national federal program that we can peg those rates to. So that's how we've been doing it. So I just wanted to express my appreciation and support to DVA for that work. We need something similar for Choices for Care. And as Molly said, we need reasonable, predictable rates that allow us to provide this service, and it's really a critical service, without the level of subsidy that's being asked of home health agencies, because our capacity for subsidizing is shrinking. Medicare, CMS is trying to reduce our Medicare subsidies on purpose. They do not want Medicare subsidizing state programs. So it's national policy to get rid of those subsidies because they don't want to use them for the purpose that we're using them in Vermont. So it's getting hard. The subsidies are getting harder and harder to achieve. And we've got this incredible wage inflation and workforce crisis. So we've got to get to a place where we have a rate schedule that's based on something more meaningful than what we have now. The last thing I just wanted, so I haven't offered any specific language because I'm anticipating, although I'm not seeing any today, that the administration may want to offer some suggestions about how to sort of better blend, say, Section 2 with Section 4. In my view, as of just reading it as a policy person, I see some kind of overlap that doesn't totally hang together. So they may be suggesting that. So I've been sort of waiting for that. But what I think what's important to us is that in Section 2, I think the concept of a rulemaking process is really to try to make sure this actually happens. So yes, it's really important to us that this actually happens. And then I think in Section 4, that's where the language that I care about the most is, which is reasonable, predictable rate schedules for Medicaid rates and Medicaid rate updates. That's really the crux of what needs to happen. But the last thing that's not in here, and that I want to remind you about, and that I may make some suggestions about, is that unlike most home and community-based services providers, we pay a provider tax. And so what that means is that it's literally a tax. It's 4.23% of most of our revenue, including our Medicare revenue. So I had this calculation done this year. It comes out to about 20% of our total Medicaid reimbursement. So whatever you're paying us, for every dollar of Medicaid you're paying us, we're getting 80 cents. Now, you impose the provider tax because it draws down a federal match, which goes into the Medicaid program. So it draws down extra federal dollars. That's why we have one. But for us, for our reality, for any home health agency, the tax is just a cost. And the fact that we're paying that tax has really never factored into whether we're prioritized for rate increases or how we look at those rates and whether we consider them, how we consider their adequacy. So there's all these federal rules about you can't make providers whole, you can't tax them and make them whole, but you can look at it in the aggregate, and you absolutely can understand that that it's a substantial impact and cost to those agencies. And if you're interested in the amounts for each agency, I'm glad to share them with you. So I just had to make that pitch. I think that's it.
That's terrific, thank you. And can we get this in writing? Can we get something from you in writing?
Yes, what I was waiting for was to propose some specific changes based on how I wanted to sort of see if it changes from the administration and work from there and work with them so that you had a package. So that was my goal, but
Okay.
see what happens next.
Senator Hardy has a question.
Thanks, Madam Chair. Thanks, Jill. I don't,
Sure.
Your point about the provider tax and the 80% Medicare reimbursement sort of in the net is a good one, but we can't, because of federal law, we can't be explicit about taking that into consideration. Can we? I don't think.
Well, what I know you can't do is make providers whole. So you can't say we're going to make sure Addison County Home Health, they're paying this much in tax and they're getting back this much in rates. No, you can't do that. You can't do that. But I think that there is more room, and I am not an attorney, to take it into account in the aggregate, to consider it in the aggregate. That's what I'm asking you to do. If you can't, you can't. But I think it's different when you're talking about in the aggregate.
Okay. I'm just wondering if we put language in about that, whether that would make it more problematic or less. I guess that's a question for our attorney, but
yeah. And I just want to make one thing clear. I think you said Medicare. So what I'm saying is that when you tax us on all of our revenue, how we think about this is what portion of our Medicaid reimbursement is going to the tax. So what I'm saying is it's the equivalent of about 20% of our Medicaid revenue is that's across the system. For some agencies, it's 35% of their Medicaid revenue is going to the tax.
Okay. Yeah, I misspoke. I did say Medicare, but I meant Medicaid.
Yeah.
Great.
Okay.
Thanks, Jill.
Sure.
Okay, this is great. Thank you. And as we hear further from the agency, we'll get your testimony in writing. So Angela Smith Jang Smith. Did I say it backwards? Smith Jang. I did say it right. You're here. Thank you for being here, and we look forward to your testimony.
Thank you, Madam Chair. I'm happy to be here. For the record, my name is Angela Smith Jang, Director of the Adult Services Division at the Department of Disabilities, Aging and Independent Living, where our mission is to make Vermont the best state to grow old in or live with a disability with dignity, respect, and independence. So thank you for the opportunity to testify today about H-153. DALE supports the establishment of methodologies for payment rates of home and community-based services and alignment of methodologies with those of other payers where it's possible, and creating a predictable schedule for Medicaid rate updates for these services. In addition to ensuring stable and predictable payments, this would also prevent the need for seeking rate increases through the legislative process every year. It's important to note that rate setting of an existing fee-for-service rate structure does not directly address payment reform or alignment with the all-payer model, for example, things like value-based payments. It's essentially one part of the triple aim of payment reform, addressing costs, but not necessarily addressing quality or access, although hopefully it would lead to improved quality and access over time. So Choices for Care is just one program under this home and community-based services umbrella within the bill. And I want to focus on providing an understanding of the breadth of services under Choices for Care and the diverse network of service providers providing those services to try to illustrate how the work envisioned in H-153 will be a major undertaking for AHS given the scope and complexity. So the purpose of Choices for Care, which operates within the Global Commitment Waiver, is to provide long-term services and supports to older adults and adults with physical disabilities, with the primary goal of ensuring Vermonters have access to these long-term services in the setting of their choice, whether that be a nursing home, a licensed residential care home, or assisted living, or a home and community-based setting. Choices for Care provides a variety of services. The traditional home-based services, where the home health agency, as Jill was speaking, would come in and provide services, provides 7 core services, and each has its own corresponding fee-for-service rate. Case management, personal care services, companionship, respite, adult day, assistive devices and home modifications, and personal emergency response systems like Lifeline. These traditional home-based services can be agency directed, where the case management agency coordinates the services, or it could also be consumer directed or surrogate directed, where the individual directs and coordinates their own services, hires their own employees to provide personal care, companionship, respite, and wages are then governed by the collective bargaining agreement between the state and the union. There are multiple alternatives to the traditional home-based service model as well. There's flexible choices, which is an option that provides an individual with a flexible budget to purchase goods and services based on their individual needs and goals. There's also adult family care home services, which is a 24-hour package of services and includes 10 different tier rates based on the level of care need of the individual. There's the residential care homes and assisted living residences that Molly spoke about in her testimony. We have enhanced residential care, again, a 24-hour package of services with 3 different tier rates based on level of care. And that goes side by side with ACCS, Assistive Community Care Services, to support those folks in residential care or assisted living who have that nursing home level of care need. And of course, then we have nursing facilities that provide 24-hour support and services as well. And they have their own nursing home rate setting rules in statute and regulation. In my testimony, I just wanted to point you to, I did include a link to our Choices for Care manual that includes kind of a more description of the different services provided. And I also included a link to the rate table, to the question of what are the rates for these different services. They're all listed out in that table. So you can see the different rates by the different services. I wanted to touch on the provider network involved in providing Choices for Care services. Our long-term care system relies on a very large and diverse network. Approximately 43 community-based organizations and 160 long-term care facilities across Vermont are part of this network. Agencies are certified by DALE to provide certain services. Some are regulated through our Division of Licensing and Protection. Others have quality oversight provided by the Adult Services Division, my team. In addition, thousands of independent direct support workers outside of any agency are providing direct care to participants at home. So just to give you a sense of the breadth of service providers involved in providing Choices for Care services, we have about 11 home health agencies providing case management, personal care, companionship, and respite under that traditional home-based model. We have 5 area agencies on aging providing case management as well. We have 11 adult day centers providing adult day services. And again, that's a package of services as well that includes activities, nursing oversight, medication management, meals, et cetera. 14 authorized agencies who provide adult family care homes through shared living providers. We have 1 agency that oversees the flexible choices option. We have 106 residential care homes, 17 assisted living residences, and 37 skilled nursing facilities. So it's quite a large network. So even if we were to contemplate a rate study of choices for care alone, that would be complex given the number of distinct services, as I said, each with their own rate, the providers, and the many factors at play. So for example, just the adult family care option alone includes those 10 different tier rates that would need to be reviewed. In addition to choices for care, of course, Section 4 of H153 includes developing a rate methodology for 5 additional programs, all with multiple services. For example, under the Adult Services Division, the brain injury program included in H153 includes an additional 10 different services with their own rates provided by about a dozen different providers. Finally, just wanted to mention that we're conflict-free case management, which the state is also mandated by CMS to address over the next several years across many programs. That may change the mix of services that agencies provide, adding an additional layer of complexity to this task. And we'll be working on a plan to address conflict-free case management over the next couple of years. So Dale would recommend that H153 be modified to allow for more time to complete the rate study, given the scope and complexity of this task. We'd recommend considering a phased approach over time, studying one program at a time to allow for that thorough review, including stakeholder engagement. H153 includes such a comprehensive list of home and community-based services to be reviewed as part of this rate study and the rate determinations. It's important that this work be done both thoughtfully and carefully. It can't be done in 1 year. Ensuring providers have a voice in the process is also really critical, since it's providers who have been advocating for this work. So we must approach the process with transparency and accountability throughout, and this will take time. So in conclusion, providing adequate and predictable rates to providers of home and community-based long-term care in Vermont is really key to having a strong and sustainable network and long-term care system now and into the future, especially given our aging population. Dale is ready to be a part of the important work in collaboration with our partners across AHS and across the community. Thank you. I'm happy to take any questions.
Yeah, that was a lot of information, and we really appreciate your taking the time to put it together for us. It's extremely helpful. And we're going to just keep moving along, but I will ask you if for specific recommendations on the timing that you were concerned about, and then that'll help us as we go through the bill. So we're going to move right along to Wendy Trafton, who is here. Thank you, Wendy, for being available to us, and we look forward to your testimony.
Thank you. Good morning. For the record, my name is Wendy Trafton, and I'm the Deputy Director of Healthcare Reform within the Agency of Human Services. I'm testifying today on Vermont's Home and Community-Based Services Spending Plan as it relates to H153, and thank you again for the opportunity. As an overview, Section 9817 of the American Rescue Plan Act provides states with a 10% federal medical assistance percentage, or FMAP, increase for Medicaid home and community-based services for activities to enhance, expand, or strengthen Hcbs under Medicaid. We're currently projecting that Vermont will claim over $67 million in funds that are attributed to this increase in FMAP. We will then be employing those funds as the state share to implement approved activities that CMS has pre-approved that are valued at $149.5 million. Currently, the agency is claiming the increased FMAP through the end of this month. We may then use those funds on activities that are pre-approved by CMS through the end of March 2024. The Agency of Human Services developed an initial Hcbs spending plan within 30 days of release of the federal opportunity, which was a requirement by our federal partners at CMS. This spending plan has a strong emphasis on one-time transformational investments that would minimize ongoing sustainability concerns while also strengthening the HCBS system. These are activities that would support the availability of high-performing providers, further care integration across the care continuum, including social determinants of health, promote value-based purchasing within home and community-based services programs, and develop infrastructure and systems to support program improvement and population health management. The initial Hcbs spending plan was developed in collaboration with an interagency workgroup that included departments that operate our Hcbs programs, including the Department of Disabilities, Aging and Independent Living, Department of Mental Health, Department of Vermont Health Access, and the Department of Health. Given the very short 30-day turnaround time from CMS, we were only able to have a modest stakeholder engagement process before the submission of the initial plan. But subsequent to that submission, we had a very well-attended town hall meeting and received public comment during a public comment period on the plan. The interagency workgroup I mentioned before reviewed all of the comments, including the 65 written comments we received with over 125 ideas and suggestions for those funding uses. We analyzed comments by commenter type and identified themes. Some relevant to our discussion today was many providers commented on the need for rate changes. Also, many providers, individuals, and families commented on the need for higher wages for certain direct care workers. Wanted to note that these comments then informed changes we made in our Hcbs spending plan that was submitted to CMS in October. We are able to update that plan on a quarterly basis. And we included in that October update the request to utilize funding to perform rate studies and develop methodology updates for Hcbs. In materials I submitted today, I included more on the spending details. One item I'd just like to highlight is the inclusion of this $390,000 for rate studies. It's in the category improved services. I'll also like to note that the funding has been approved by CMS in the plan and was included in the FY22 BAA appropriations. I'd like to note my colleagues Alicia Cooper and Pat Jones can provide further detail on the activities and that impact of H153 on those activities. Thank you.
A lot in a short time. Thank you. We have your slides, and we'll, as we have questions going forward, we'll get back to you with those questions. So thank you very much.
Appreciate
Again, being comprehensive, really appreciate it. And we're just going to keep moving only because of the time we're in. Alicia Cooper is here. Alicia, thank you, from DEVA. Why don't you introduce yourself for the record, and we'll listen to your testimony.
Wonderful. Thank you very much. Good morning, everyone. My name is Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access, and I am joined this morning by my colleague, Pat Jones, the Deputy Director of Payment Reform for the Department of Vermont Health Access. We're happy to be here today to provide comments on H153, and I believe that our testimony will follow nicely from the testimony you've already heard from both Angela and Wendy. DEVA has staff that is dedicated to reimbursement, rate setting, and payment reform. And in recent years, these teams have increasingly worked with the other departments within the Agency of Human Services to evaluate and change how our Medicaid program pays providers for a variety of services, including more traditional medical services, as well as some services in the home and community-based service area. We have taken on new projects annually in recent years, recognizing that each project requires dedicated time and resources. And as Angela mentioned in her testimony, we recognize that the projects that we're talking about within H153 in the home and community-based services space include a number of different service lines, provider organizations, and existing rates that would need to be evaluated carefully. And so I think DEVA in its testimony would like to reinforce that time, in addition to resources, will be very important as we contemplate taking on this body of work. To share some additional details about projects that we have engaged in recent years and examples of the process, I'll turn to my colleague, Pat.
Thank you, Alicia, and thank you, Madam Chair and Committee. For record, my name is Pat Jones. I'm the Deputy Director of Payment Reform for DEVA, as Alicia mentioned. Just a few key points that we want to make about H153. First of all, as others have said, DEVA has demonstrated an ongoing commitment over time to periodic review of provider rates, both for the programs that we fund and for other departments' programs. And two examples of that, Jill already mentioned the home health services work that we have done. And another example is the Children's Integrated Services Payment Reform Initiative that involved a rate study. And both of those culminated in rate changes for providers. We can take a couple of different approaches when we're engaging in rate studies. One is a provider survey if providers are willing and able to engage in that. And that was used in the Children's Integrated Services project. Or we can build models based on existing data that we have and existing methodologies, and the home health services example use that method. Regardless of which approach we take, and that this has been reinforced by other speakers this morning, but provider engagement and feedback is really critical, regardless of whether it's a rate study or building a model. Each rate study honestly takes months of concerted effort. It involves provider time and resources, state staff time and resources, and contractor time and resources. So these are not quick and simple processes. I'm going to sound like a broken record here, but given the large number of home and community-based service, mental health, and substance use disorder programs that would require studies in H153. And we estimate that there's somewhere around 20 programs, and Angela outlined in excellent detail just how complicated one of those programs can be. It isn't going to be possible to complete them in a way that would ensure meaningful provider engagement and a good understanding of the existing data and the underlying methodologies in a year or less of time. Others have also noted that we'll need additional DEVA staff and contractor resources, and given that and the changes that have come about that Wendy described with the federal funding opportunities, and updated fiscal note is probably in order. The last slide in our presentation is a very dense one, but what we wanted to show here is what a rate study might look like for each of the different programs and services that we would have to conduct them for. Every rate study is unique, but invariably the process is quite complex and requires flexibility. So for example, we would generally start out by meeting with staff and providers to make sure that we had a really clear understanding about the program, the population that's being served, the services themselves, and then how they are paid for currently. We would want to really research the methodologies that are available that could be used to determine rates. That may be Medicare, if it pays for services, as already mentioned, for a lot of these services, Medicare doesn't pay for them. So we would really want to look at what other payers might do, what's happening in other states, and so forth. We need to determine whether a change in methodology is warranted, and if so, we need to engage in a design process. That's a very extensive process and really one that demands significant stakeholder engagement. We'd want to estimate the costs of providing the services, and that's technical work, and that would definitely include contractor services. And it could include creating and fielding a provider survey, as previously mentioned. Some additional activities would be added by H-153. One of them is the cost of state and federal mandates. That could be a heavy lift, particularly on the federal mandate side, in terms of understanding what the mandates are and developing models to estimate costs of those mandates. So that's a concern in terms of adding time and complexity to the process. Estimating impact of inflation, the impact of labor costs, and then, ultimately we determine rates for the programs. We estimate the budget impacts of the rate changes, and then the bill would require providing reports to communicate results, findings, budget impacts, and recommendations. So that's the type of process that we would undergo for each program and services within each program. So I'll just close again by saying that DVHA has been committed to doing this work. We will remain committed regardless of what happens with H-153. It's a process that we think has been a positive one, and it was nice to hear Jill reflect that the home health agencies see it that way as well, but it's work that we're committed to doing on an ongoing basis. Thank you so much for your time.
Well, thank you both. This is helpful, and it's great to hear that everyone is sort of moving along the same track. And I guess my question would be the same question that I asked earlier of Angela Smith-Jang, and that is to provide us with maybe the timeline that you see that may not be explicit in the bill. So it'd be helpful. So Nolan, you have a comment?
Can I ask a question?
Yeah, sure. You may ask a question, and then we're going to.
This is for Pat and Alicia, or actually Wendy. How is what's in the bill different than what you have in the BAA, the 390,000 that you budgeted? How is that, what you budgeted in that for BAA, different than what's in the bill? Because I hear that you've budgeted in the bill, and now I'm hearing that you need more. So I'm trying to understand how it's different.
I could speak to that, and then Pat, do you want to add on? My understanding is it's really related to the ongoing costs because the FY22 BAA was based on the Hcbs FMAP opportunity, which is the one-time investment. So that does not anticipate an annual process.
Yeah, I would concur with that. The funding in the BAA is for contractor resources. We would need additional to do this amount of work in a more compressed time frame. We would require additional staffing. For those initial rate determinations, that could be, temporary, assuming we could find a staff member. And then for the ongoing annual rate determinations, again, for, potentially 20 or more programs, that ongoing work would also require additional staff and, frankly, additional contractor resources as well.
Thank you. Appreciate it. The clarification.
Actually, a further clarification. Maybe Nolan got this already, but so the money in the BAA was just specific to the work you're going to need to do for the FMAP bump, and then you'll need additional funding for the work that's in H-153. Is that what I heard? Or
The 390,000 and FY22 BAA is work on rate studies and methodology updates, in some ways in alignment with H-153. I think the concern we were noted was language in H-153 has sort of an annual component that couldn't be covered with these dollars that have an end date of March 2024.
okay, thanks.
Okay, good, thank you.
Thank you for the clarification.
Yeah, good clarification. So we're gonna move along to Julie Tesler, who is here. Thank you. And you are here in place of Mary Moulton, I guess, but thank you for stepping in.
Thank you for this opportunity. Julie Tesler, I'm the Director of Vermont Care Partners, the Vermont Council on. My dogs just decided to start barking. I'm sorry. Hopefully I won't have to
You know what? We are now very thrilled about hearing the normal sounds of dogs and children.
Great. Just very briefly, Vermont Care Partners represents 16 designated and specialized service agencies that provide developmental, mental health, and substance use disorder services. Annually, we serve over 36,000 people as clients. And then there's a number of people we serve who never become clients, whether it's in crisis services or community outreach or in the schools. We've got about 5,000 employees, or we wish we had 5,000 employees. Right now, we have a 20% vacancy rate, so we only have about 4,000 employees. And the state is funding the system with, well, as a total, it's about a $500 million system. The vast majority of that are Medicaid funds and some state funds and other federal grants. We have 1.5% of our funding comes from Medicare and another 1.5 from private pay, private insurance. So we are Medicaid funded doing the work of the state and the federal government. We strongly support H-153 because you've worked with us in the past around this language, looking to find ways to really fund the services at their costs, and 153 hopefully will strengthen that. We've really never had greater demand, and it is important. I think Representative Wood was right. We don't really know the cost of services that the state is making this huge investment in. So I think it's very appropriate that the state do that. And I do hear that it is a costly, time-consuming process. And we are appreciative of the work that DEVA has been doing with Department of Mental Health and with Dale, where we have begun looking at cost and payment methodologies. So some of that work is underway. It is important that we really have a good sense of cost. So I agree with them too that it's not easy. So we would to look at labor market, which is critical. And this year we all know the labor market has just changed significantly. You really need to say, okay, what are the positions in these agencies that look similar to other positions? And that takes some effort, but we've actually identified 8 positions in our system of care that represent 80% of our staff. So we will very much work collaboratively with state government to do this analysis. And we appreciate, I hear what they're saying, that it's costly to do this on an annual basis, but maybe if it's not the whole thing, at least maybe some things like labor market could be looked at annually, or you can find ways to determine the change without necessarily going back and doing the original analysis on an annual basis. And we'd be glad to work with state government on that. And we do know, I mean, we appreciate very much too that state government is trying to ensure that there are enough Medicaid resources in their negotiations, and appreciate the work that Wendy Trafton has done to identify dollars to do some of this analysis. But currently, because we don't have these processes in place, it sets up a dynamic where the state invests Medicaid resources in where either the need is so immediate that that has to be done, like in the Brattleboro retreat, we needed to keep inpatient psychiatric beds open. or their ongoing processes that they refer to, things like setting rates, Medicaid payments similar to federal requirements and using those formulas. So this year, mental health private providers' Medicaid rates for their fee-for-services went up by over 17%. And so when my providers look at that, and I said, well, why did we get 3% if that's 17%? It's because there isn't a process. And because when the budgeting process happens, when you don't have the information laid out for all the providers and look at your system of care as a whole, you can't set the priorities in the way that good budgeting does, where budgeting is a priority setting process, but you need the information on all the providers to make the choices. And of course, from our perspective, we're serving the Vermonters with the most complex needs, the highest needs, and people are very, very vulnerable. And right now, I have agency directors saying they don't feel secure that they can really ensure the health and safety of everyone they serve because of our staffing crisis. We're not getting out there often enough. Our staff turnover is so high that a number of the staff are new and learning their jobs as they go. We're asking people to work really long hours, and you make mistakes when you've worked over 80 hours in a week. So we're in a very concerning state, and it's not just the quality of the services we're providing. We also have services we're not providing. The HCRS is closing intakes on their outpatient services in Windham County because they just don't have the clinicians to provide the service. In Addison County, I think Senator Hardy knows, they've been struggling to keep their emergency services team staffed, and they've been understaffed for quite some time, and now 2 more staff have left, leaving only 2 staff for 24/7 coverage. Of course, they're going to do everything they can to figure out how to have that coverage. They've reached out to other agencies. They'll ask staff to do more, which is we've been doing that throughout the pandemic, is asking staff to take on additional responsibilities, especially in emergency services and residential services. So for us, this is a very critical issue. And I do hear that this will take time, but I appreciate that the committee has been supportive of this, that the agency understands our interest in a rate setting process. And I also want to express my appreciation that in S285, you also acknowledge the need to invest and ensure that the community-based services have appropriate funding to do our share of healthcare. And without that, we'll end up investing more in higher cost services, because mental health services, as Patrick Flood testified at this committee, they really impact not just future mental health and address the concern of increasing acuity, it also affects regular health and physical health. And an easy example of that is alcoholism. If you can't address the substance use and alcoholism, people will end up in the hospital. But in mental health, depression and anxiety also affect health significantly. So we think this is a very important bill. We're glad to work with others to make it a reality and to do the analysis, and have been working very collaboratively with the departments we do work with on the mental health and developmental disability end, looking at costs, figuring out how to address that. And honestly, I think even if it means that we can't do as much, we need to do it well, because if you don't make the decisions at the state level, budgeting what you're going to fund, then you end up with things happening in the community that you didn't want. Nobody wants to end outpatient services or emergency services in communities. But if we don't do an analytical approach and a proactive approach, things are just breaking down. And we want to have people have health and safety. We want to feel confident we can ensure that. We want people to be able to fully access quality services and not be waiting for months for care that they need. So we see this bill as a tool to achieve that. Thank you for the opportunity to speak to it.
Well, thank you very much. You went all the way through, and as folks were talking, I was thinking about what we have embedded in S285, and you identified it, so it's great. If you could please get your testimony in writing, we'd greatly appreciate it. That'd be great.
You're welcome. I will do that. I haven't written it yet. I will. What did I say?
figured, no, that's fine, but it will be helpful, thank you. Okay. So, thanks everyone, you know, we do have a little bit of a time crunch today, but we are not finished with H-153, and we actually look forward to staying connected with each one of you as we go through the bill and try to make some improvements to it so that everyone is satisfied with the direction. And the timing sounds like it's an issue, but so we'll work on it. So thank you very much. Appreciate your time today.
Thank you.
Take care. And we're going to move on to look at the amendment that appropriations has, a substitute amendment, I guess it is, right, Jen? Okay. That appropriations has put forward on S-285. Looks like they rewrote the whole bill.
They did not. Tried to write it in a way so you could see.
So you just did a strike all, right?
I did not do it.
No, you didn't do a strike all. Okay.
All right. So good morning, Jennifer Kirby from the Office of Legislative Counsel. We are looking at S-285 and the Appropriations Committee substitute amendment, which I think is marked as draft 3.1. So S-285, as you remember, is your bill that you have retitled as an act relating to healthcare reform initiatives, data collection, and access to home and community-based services, even though that's not titled yet. And so the changes, sort of a broad overview of the changes that appropriations is making, is to take the money out of sections 1, 2, and 3 and create a new section, section 10, where the money part lives. So in section 1, instead of appropriating $1.4 million to the Green Mountain Care Board to work on the hospital value-based payment design, it is taking that money out and replacing it with intent. So it is the intent of the General Assembly that, to the extent funds are allocated for the purpose, the Green Mountain Care Board would, and then goes into the existing language. And similarly, in the report section, subsection B, it strikes that out and replaces it with similar language, but instead of talking about update on the use of funds or providing information on its use of funds, it's talking instead more generally about its an update on its progress in completing the responsibilities set forth in subsection A and reporting on its activities pursuant to subsection A. So you'll see that in the first, second, third, fourth, fifth, many of these instances of amendment are taking out. So section 2, we had appropriated $2.5 million to the Green Mountain Care Board to do the healthcare delivery system transformation. This would replace that with intent that the board, in consultation with the Director of Healthcare Reform, and to the extent funds are allocated for this purpose, shall build on successful healthcare delivery reform efforts by, and then it goes into the facilitation of the plan, etc. It does lose in that piece the language about the consultants with expertise in community engagement. I don't think that part. Was something they decided to include. So the fourth instance of amendment is, again, in subsection C, where you had the board using a portion of the funds appropriated to it to contract with a primary care provider. This is changed to intent that, to the extent funds are allocated for a purpose, the board would contract with a current or recently retired primary care provider. And then subsection E is the reporting. So I pulled out the language about updating and reporting on use of funds, and instead using similar language about completing the duties set forth and activities pursuant to this section. Section 3 did strike out in its entirety just because of the way it was structured. So it's still very similar still directs the Director of Healthcare Reform in collaboration with the Green Mountain Care Board to design and develop a proposal, but instead of referring to, sorry, I'm trying to compare the differences here. There were parts of it that did not work. So I just moved them. So I just basically reorganized because the money part was not coming in. So subsection, I needed to get rid of subsection B, and so I moved everything up a level. To create A, B, and C. But otherwise, what it's doing, the function of it is the same until we get to the part about supporting the development and design of the agreement and appropriating money. That part comes later.
So just overall, and
Yes, and we're about to get to the important part, which is the.
yeah, okay. But overall, in this, the language that is in the underlying bill is still pretty much
all of it, right?
Yeah.
Pretty much all of it. There is some of the modification or modifier pieces about things like that community engage, who they consult with or contract with, what kind of experience that person would have. That language specifically is not included, but I think most of it is.
Yeah, wait, you haven't done the last
I have
one.
not done the last one.
No, keep going.
Okay, so the seventh instance of amendment strikes out the effective date section and puts in a new substantive section and effective date section. So the new section 10 is where the money comes in and some more of connecting that to the process. So first, it would appropriate $1 million to the Green Mountain Care Board in FY 2023 to begin the work described in sections 1, 2, and 3. It also appropriates $550,000 to the Agency of Human Services in FY 23 to support the work of the Director of Healthcare Reform in designing and developing a proposed agreement with CMMI as set forth in section 3. So that's subsection B is really what had been for the Director of Healthcare Reform in section 3 in your version. And then subsection C appropriates the remainder of that to get up to that 5 million that you had done. So 3.45 million is appropriated from the general fund to the Green Mountain Care Board in FY 2023 to further execute the initiative set forth in sections 1 through 3, provided, however, that the board shall not expend the funds until the Health Reform Oversight has reviewed and approved the board's proposed plan and timeline in accordance with subdivision 3 of this subsection. And then it talks about, in order to provide the greatest likelihood of achieving meaningful results from the initiative set forth in sections 1 through 3, the work of the Green Mountain Care Board will require sequencing, coordination, and collaboration with the Director of Healthcare Reform and the Agency of Human Services. This is especially true in light of the potential changes to the Global Commitment Waiver, the All-Payer Model Agreement, requirement for accountability for total cost of care, the scale of Medicare participation in the All-Payer Model Agreement, the need for collaboration across the continuum of services in healthcare and human services systems to enable the delivery of high-quality care and services in the most appropriate settings, and the short, mid, and longer-term strategies to address significant workforce challenges in the healthcare and human services systems. Subdivision 2 directs the Green Mountain Care Board to develop a plan and timeline for pursuing hospital value-based payment design in accordance with section 1, for developing a patient-focused, community-inclusive plan for healthcare delivery system transformation as set forth in section 2, and for the board's role in designing and developing a proposal for a subsequent agreement with the federal government as set forth in section 3. It requires the board to collaborate with the Director of Healthcare Reform in developing the plan and timeline to ensure appropriate alignment with the state's healthcare reform goals and with the timing of waiver negotiations with the federal government. Then in subdivision 3, on or before October 1st, the Green Mountain Care Board would provide its plan and timeline to the Health Reform Oversight Committee. If the committee is satisfied that the plan and timeline are achievable and are appropriately aligned with the work of the Director of Healthcare Reform, and the committee shall, by majority vote of the members present, authorize the board to expend the funds appropriated by this subsection. If the committee determines that the plan and timeline are not achievable or are not appropriately aligned or both, the committee shall recommend appropriate modifications and when satisfied with the plan and timeline, shall authorize the board to expend the funds. And so section 10 would take effect on July 1st. The rest of the bill would take effect on passage.
Okay. So overall, what the work that we've done is pretty much intact.
Right.
Yeah.
Overall, the work you've done is pretty much intact. The money would go out, a first amount to the Green Mountain Care Board to get started on their work. The amount to the Director of Health Care Reform would go out, and then the rest of the Green Mountain Care Board money would be contingent on approval of their plan and timeline by the Health Reform Oversight Committee.
I think in our bill, we had a report to the HROC.
You do, and there's still reports.
Yeah, okay.
This version of this amendment is this, it says 3.1, so this is, didn't they pass something originally? Is this the second version of?
This is the subsection.
I looked at a different version of this, okay.
So
All right.
my understanding, they voted this one out yesterday afternoon, so it's
Okay.
not the one that's in, may not be the one that's in the calendar. Or
Right,
may
yeah,
not
I think
have
they
the one.
replaced the one in the calendar.
Okay,
They actually voted on it yesterday.
so the language that I worked really hard to get in here, I know it's sort of still in here, but they took out the language about the consultant with expertise and rural whatever we ended up with.
That was the section that was the one, that was what was missing.
Yeah, I mean, I know it looks like on page 6, they have paragraph 2, which is a patient-focused community inclusive plan, but it doesn't talk about community engagement at all. Am I missing it anywhere else?
I don't think so. I mean, it didn't go into the details of hiring consultants. It didn't specify that part, and that was really the piece that, so it didn't take out, the language in your underlying bill all about the community engagement process.
It did not?
It did not.
So
It
where
took
in the
out-
bill is, I'm looking at
Well,
the bill
because
now.
they didn't strike it out. So in section 2, the changes that they made to section 2 of the bill are in this lead-in paragraph to A. So where your bill appropriated 2.5 million, talked about engaging consultants.
Yep.
They replaced that with intent language that the Green Mountain Care Board, in consultation with the Director of Healthcare Reform, and to the extent funds are available, shall, and then we pick up build on successful healthcare delivery system reform efforts by, and then you still have 1 and 2, you still have B.
The community engagement process shall, that's still.
Yep, that's still in there. And
Okay.
then C gets changed a little bit because there aren't funds, so we can't talk about using a portion of the funds. And then D stays the same, D1 and 2, and then E is different because we're describing differently what they're reporting on because they didn't get funds in this section.
So they really, what I'm hearing that they did was move the money to the end, and then modify the language a little bit, but mostly to have that accountability or benchmarking with the health reform oversight committee.
Right,
That's
it's
those are
really
the
that check-in and approval process
Yeah.
before the money can be spent.
And the approval.
Sorry, go
The
ahead.
approval process, November 1st, is that
I
first?
put October 1st as the deadline for on or before when they would make their plan and timeline. So honestly, if they had their plan and timeline ready by July 1st and wanted to talk to HR about scheduling a meeting and getting that approved, it could happen earlier. It's an on or before.
Okay, great. I was just concerned about things getting delayed too much. The original amendment had November 1st. That's what I remember reading it. So
Yeah, it might have.
Yeah.
It was,
And so that was a concern that it would get
Right.
pushed out too
But
much.
again, it's an on or before,
Okay.
so the earlier into FY23 they do it.
Okay.
Potentially the earlier that the money could be released. And that's also, I think, why the appropriations committee gave the 1 million upfront at the beginning of FY23, so that without requiring a check-in, so that if they needed consultants or others to help with the planning and preparing the timeline and the plan, or in understanding what they would be proposing, that they could have that.
Okay.
Any other questions? Good. So I might want to chat with you before I present the bill, get ready to present the bill on the floor, just about how to integrate, look at those together, just so we're clear on that. I think we're good. I think what we'll do is we'll just go offline and we've had a big day.